Well, thank you. From the international standpoint, the ASCRS Foundation is really all about partnering with what we feel are some of the most impactful efforts and groups and organizations, and facilitating those of our members and our industry partners that want to collaborate. And so, Lisa and Susan, Stan are some of the great partners that we have, and this is wonderful to have all of this showcase this morning. I'm kind of the substitute presenter. Lisa usually has someone from Erevan, and due to travel conflicts, they couldn't stay today. So that's really what I just want to touch on, because it was really when I first saw this in 2003, and this is the title of my talk, that I really learned about MSICS and became a convert. So this is certainly the biggest challenge that we face in cataract surgery. It's not developing accommodating IOLs, but the backlog of blindness. And realize it's, I think you all know this, it's really the bottleneck is surgeons, and then having the few surgeons that we have be as highly productive as possible, but realizing that what we do is just not going to deal with the advanced cataracts there with an acceptable complication rate, and then we have cost constraints. So this is just a video that Dr. Venkatesh made at my suggestion after I saw this, because I said, first of all, every cataract surgeon needs to come here and see what's going on, but lacking that, can you make a video? So this is an unedited video of Dr. Venkatesh doing manual small incision, and this is actually in about 2003. And he put in the picture-in-picture to show what's actually happening. And you see that there's two beds alongside each other and two separate teams, and then he is swinging his microscope back and forward from one eye or one patient to the other. So just every so often look at that picture-in-picture frame, and you'll see another patient being brought in and prepped and draped, so that when he is done with this case, he just has to swing around, and that's of course everyone's dream, no turnover time. And he basically does not separately change his gloves and gowns, but just washes his hands in an antiseptic. So this is sutureless temporal surgery. You see here he's doing a manual capsulotomy, but it is a capsulorhexis. I watched him do 16 cases an hour, and the best people at Erevan can do that kind of productivity. You see the next patient being positioned there by the separate team. And, they still round up everyone from a weekend cataract camp and transport them into one of the major hubs. And whether it's 200, 300, or 400, they'll just do them all Monday afternoon. That's a year's surgery for a busy American cataract surgeon. Then it's all manual. I mean, the genius of this is not just the speed and the effectiveness, but it's a low-tech solution. I mean, everything we're just accustomed to having technology solve everything, and it certainly can. But this is reverse. This is the reverse, going low-tech to get this out. And there's this beautiful choreography and orchestration of everyone in the operating room being so efficient, and part of how that's done is through standardization. Everyone has to do the same thing. We can't have, Dr. Chang likes this instrument, and Dr. Park likes this other instrument. There's the PMMA IOL going in. The cost of this now is just a few dollars. And everything that they can reuse, they will reuse. And now you see that the next patient's being draped, and he's just going to inject some antibiotic, and it's all sutureless. And by going temporally, they maintain very little in the way of astigmatism. The endophthalmitis rate, and this is just a current publication that's online now for ophthalmology, hopefully in the June issue. And we showed that for MSICS, it's 2 per 10,000, and phaco 1 per 10,000 if you use intracameral moxifloxacin. So here's a more mature lens. You see that the patient he's just operated on is now being patched up and will be led off of that table. This is one of the few studies of this technique. They published this in the BJO. And look at this. This is 600 cases, but that was 2 days' worth for 3 surgeons. And that's what they averaged there. And 90% of the cases were 2,200 or worse, so they're cataracts like this. And I think that's the thing. We see the numbers, but we forget that these are cases that we see once a month, if that. And this was just showing, using the WHO standard, 90% were better than 20/60 afterwards with 6-month follow-up, and only a 1% vitreous loss rate, despite the fact that many of these were traumatic, subluxated, pseudoexfoliation, rock-hard lenses. This is all the vision of Dr. Venkataswamy, who modeled this incredible system after McDonald's, because McDonald's doesn't give you a lot of choices, but they do give you a lot of bang for the buck for a low-cost meal by standardizing everything. And whether it's how the nurses sterilize things or set up the tray, the instruments that the doctors use, it is all standardized. And through this efficiency, they're able to do 60% of their care basically at no cost for charity patients, subsidized by just those that pay if they can. So here you see the white lens and the nucleus coming out. And, there's just no talking. They just hand them. It's an assembly line in the best and most positive sense of the word. And there you see some of the costs, and literally, depending on what you want to include, $15 to $25 per case. But it's the ability to leverage this one skilled surgeon into this productivity by surrounding them with this incredible team that's so fantastic. So I'm just going to show a little bit of an MSICS case of my own, and my learning curve, will be like yours. You start off with a large enough incision, but this is my own case. This is just a shallow chamber with the rock-hard black lens. And the scleral pocket, I think we have that skill, but it's a little different when you go this large. And you just have to realize that although my incision is smaller in length than the diameter of the cornea, I'm really funneling it. And look how far up into clear cornea and to the sides I'm going. Then I make a small little puncture to get my viscoelastic in. Now, you can't use a Malyugin ring here. So what I'm doing is, this is the Nepalese technique that Dr. Ruitt and Dr. Jeff Tabin have taught me. And even though I know this thing is just enormous, and this again is being done in my own surgery center here in California, I'm making small sphincterotomies. You certainly keep this less than a millimeter long so that you don't transect the sphincter. And it still doesn't look like you've accomplished much. We will stretch that, but it actually is enough to get the nucleus out in one piece. So you see the glassy glow from that fossilized nucleus underneath the capsule. So we'll stretch here, and then we'll put in trypan blue. I think trypan blue has made life easier for all of us, both in the MSICS as well as phaco. You just layer this down. And then, although at Erevan they would do a capsulorhexis, I think for most of us, I would do either a can opener. The Ruitt Nepalese technique is to sort of make a little triangle and to have a little flap that with the base of a triangle that you then amputate. You don't really need to rock or rotate the nucleus because, as you'll see when I go in with my irrigating Simcoe, it's really a hydrodissection cannula on steroids. It's just a high flow from a gravity infusion bottle. And so once you learn this technique, then hopefully you'll be able to teach it. But it's really hard to go into these settings armed only with phaco. because you end up doing phaco when it shouldn't be done. And then you have this sort of selfish benefit of, again, this is in my own practice, I increasingly resort to this just because the corneas are so much better. Now watch, here's the hydrodissection as I go under the capsule, into the cornea, onto the sides, and then I'm rocking a little bit, and that rocking kind of eventually will tip the left-hand pole upwards, see if I can tip it up, and if I can go around it. You know, I didn't quite get around there, just try again, tip it up, try to rock around it. Oh, I'm under it now, it's just like a spatula, and then I can sort of lift this a little forward. Now the fluid sort of propels this toward the incision, so you're really guiding it out rather than clawing it out, and then there it is. So in the developing world, you know, you pull this out. The PMMA IOL I'm going to use is an Alcon CZ70, and so we still have those. It's 14 millimeters overall length with a 7 millimeter diameter optic, and that works beautifully here with the can opener. And although the chamber will shallow, this you always keep the port facing up. And this is again the Nepalese and the Irvin technique. So there I sort of have a pseudo capsular bag, but really it's not all going to stay there, and hence the desire for a larger optic, and we're in there. Now, at Irvin and Nepal, they would certainly not suture this. You know, I was a little chicken, I put in one suture, but this is still a lot better than 10 sutures or whatever it is, and very astigmatically neutral. And you realize that you know, you get sort of more macho points for doing phaco, but boy, the cornea looks a lot better, and you're just not going to drop a nucleus. And I think that's the really, I'm not sure this has been pointed out, but you know, in a resource-poor environment, the worst thing you can do is drop a nucleus because there's no vitreoretinal surgeon to fish it out. And so the beauty of this technique, now this is just one paper that we did at Irvin, which showed, you know, this is one hospital for a year, so 80,000 cases. You know, our surgery center in California would do 5,500 cases a year, and we're the busiest center in Northern California. And of this, if you look at the complication rates, MSICS and phaco were the same. The extra cap, that's biased because they were used for traumatic cataracts and so forth. But if you look at these complication rates overall, you see that as you get less and less experience, fellow, resident, visiting trainee, the complication rate goes up. That's logical. But if you look at MSICS, the rate does go up. But look how higher the complication rate goes up with phaco. And so if you look within staff, okay, experienced people, it's the same. It's less than 1% in both groups. But here's fellow, but look at the residents, 8% versus 1.7, 11% versus 3.7 in terms of complication rates for doctors that are visiting from other developing countries. And this is just highlighted there. So I think that I do this just to, again, show you what is being done at the pinnacle of efficiency with manual small incision. But as I say, that's really what convinced me that this is the solution to cataract blindness. Thank you very much.